Good afternoon. Welcome to our webinar on mobility management, veterans transportation to healthcare. Today, we will have speakers from the 3 TA centers, NADTC, NCMM, National RTAP, and from our state and community programs that will bring us examples on how they operate and plan veteran transportation to healthcare.
To participate today, please use the chat to chat with hosts and panelists, as well as with other participants in the webinar. Please use the Q&A function to ask questions and reactions to share your reactions to the content. As Angela just mentioned, we will discuss mobility management, coordination, and partnerships with presentations from the National Centers for Mobility Management and the National Aging and Disabilities Transportation and Disabilities Transportation Center, as well as Veterans Transportation Program from the VA and the Veteran Transportation Service best practices from the Office of Rural Health. We'll hear about programs from the Oregon Department of Transportation and from United Community Health Partnership Agencies. If you have questions, please save them for the end or ask in the Q&A. The FTA Technical Assistance Network is a partnership that works to promote mobility for all through the provision and coordination of transportation services through CCAM, which is an interagency partnerships established to coordinate the efforts of federal agencies and that fund transportation services for different populations. Today, the National Aging and Disability Transportation Center, the National Centers for Mobility Management, and the National Rural Transit Assistance Program have worked together with the Veteran Affairs offices to bring this webinar together to help get veterans transportation to healthcare. In addition, there is the TACL, which is the Transportation Technical Assistance Coordination Library, which is a resource that you can use to find materials that can help you coordinate with other agencies to achieve services like these. Today, you'll hear from Anjali Dixon and Ken Thompson. Anjali has spent a little over 15 years in the US and abroad in the transportation industry in the public and private sector as a designer and consultant working in the various STEM fields of education, architecture, engineering, and urban planning. Before joining NCMM, Anjali began her transportation career with the University of Kansas on Wheels and Transsystem Corporation simultaneously. She later joined Missouri DOT's multimodal transit team and then the Office of External Civil Rights. She was able to chair the KU on Wheels transit system and work on a variety of projects spanning from bike pedestrian rideshare, bus rapid transit, major light rail projects, ADA planning, and more. Anjali serves as the current Chief Program Officer for TransitCon. She has an associate degree from State Technical College of Missouri in Civil Engineering Technology and a bachelor's degree in architecture and a master's degree in architecture and urban planning. Emphasis in transportation and transit, urban social issues from the University of Kansas. Coming from a large military family and serving as a military spouse and local volunteer at the Salvation Army Shelter Pantry, she works hard to connect veterans to resources in her community. She lives in Jefferson City, Missouri, and is the mother of 2 children. Ken Thompson joined Easter Seals Project Action in 2002 as a training and technical assistance specialist and is currently the Technical Assistance Director for Easter Seals Transportation Group. He supports the NADTC by providing technical assistance, training, and information to customers on a variety of issues, including accessible transportation, the ADA, veterans issues, building partnerships, and service planning. His over 20 years of experience in working with human services includes managing a human services transportation system that follows a US Navy stint while working in aviation. He grew up in a career military family and attended military schools overseas. Ken holds a master's in public affairs and a bachelor's from Hood College in Maryland. He has completed the ADA Coordinators Training Certification Program, University of Missouri College of Human Environmental Sciences, and is a certified information and referral specialist from the Association of Information and Referral Systems. Take it away, Ken and Anjali.
All right. So Ken and I are going to tag team here. I'm going to start off with mobility management, coordination, and partnerships as the top of our presentation today. I am with National Center for Mobility Management, the Eastern Skills Group, and the regional liaison. Oh, Ken, I think you pressed it too. There we go. So if you could go back to the slide before that, Ken, I think it keeps rolling. There we go. Right there is fine. Okay, if you can go to the next one. Sorry about that, everyone. And the next slide, one more. All right, so National Center for Mobility Management, we are one of the TA centers. We work through a consortium. There are three groups, which is APTA, CTAA, and Eastern Seals. Our main mission is to promote customer-centered mobility strategies. We're working towards advancing good health, economic vitality, self-sufficiency, and communityship. We really are promoting what we call cross-sector partnerships, or CCAM. And that will be a major goal this year, making sure that we partner with all organizations and agencies across the states and local levels and regional levels to help making sure that we provide diverse mobility options in communities, whether it's to workforce, to healthcare, to school, or to make sure that people are maintained every day, getting to vital needs in their life. Next one, Ken. So what is the role of mobility managers? We kind of want to touch on that a little bit, because mobility managers do play different roles depending on where they are housed. We know today that this webinar is focused on veterans. And so later on, they will touch on the role that their mobility managers play when they are called VTS coordinators. And so they all have various titles, but we want to make sure that the role that they understand how to coordinate, whether it's within their agency or outside their agency with their other transportation agencies in their communities. Want to make sure they understand CCAM, the Coordinating Council on Access and Mobility, and developing those partnerships across agencies, and also want to understand what we call the federal funding braid. And we have a wealth of documents on our website that break those down for you. We also want to focus on developing networks and relationship with non-traditional partners and organizations. And that's where we share a lot more about cost sharing and also more about partnership funding models. Next, Kim. And here, I'll just briefly touch on the CCAM mission and organization. We know that CCAM was established in 2004 through an executive order. This is the original organization and the agencies that started out the mission with CCAM, and since then it has grown, and I will let you read up on that a little bit further. But their main mission is to improve availability, accessibility, and efficiency. And the targeted populations are those with disabilities, older adults, and individuals low income in communities. Next. And this just gives you a little bit of a breakdown of the departments that may fund human services transportation. And these are organizations that have a variety of cross partnerships as well. Next, Kim. Want to touch on some of our e-learning modules back there that you can access through our site through the NCMM resources. And these modules can help you develop those partnerships through a lot of our e-learning courses that we have on mobility management, partnerships, how to develop activities, and also how to use some of our tools and toolkits in making sure that there are diverse mobility options and having those diverse partnerships. And next, Ken. Another tool we have is Mobility Management Connections, which is MMC. We welcome you to join this platform where we have mobility managers across the board, whether they are housed in a social service agency, a transit agency, a city, a nonprofit, a food pantry, or with a VA. You can hit next, Ken. And this is a platform where we have champions. We have a lot of tools and resources. We have webinars, book clubs, a lot of community monthly activities, and also discussions where you can post things and get feedback. And it's just another way to network with your peers across the country, also across, even outside the country, across the world, to see what they're doing, what activities, as far as mobility management activities that they are conducting. Very, very helpful tools. And so we invite you to join this platform. It's a safe space. There's no vendors, no sales in here, but it's very, very active. And people have a great time learning and sharing their research and their tools that they can use and apply to their communities and their organizations. Next, Ken. And this just tells you how to sign up for it. Skip that one, Ken. Go to next. And I think that Nellie went ahead and touched on this. I just want to reiterate our TA centers. NCMM, NADC, National RTAP, Shared Use Mobility Center, and NCAT. And we also have another center, which is the Transit Workforce Center. It's not placed on here. And next. And I'll hand it over to Ken, Technical Assistant Director with NADTC.
Ken, you're muted.
Hi,
Still
Ken.
muted.
There you go.
I'm on now. Good. Start again. I thought I was unmuted. But anyway, I'm going to talk a little bit about partnerships as they are the key to mobility management. And, you know, when we talk about mobility management, it's not one organization, one group, or, you know, entities providing the mobility management. It's really a community. And so we like to think of mobility management as collaborative efforts that includes a bunch of different entities. And we like to even say that the riders and people getting the rides are really part of that mobility management effort. So you're really going to find out, what do people want? Talk to those individuals, talk to the riders, talk to the people that need services, and see how you can meet those needs. And then I added the transportation providers, but the twist here too is you want to include public transportation and private transportation as part of the mix, because providers aren't always, you know, the public transit systems that you see going around town or providing large scale services. It can be private providers, individuals and companies that have vehicles and drivers that provide services, and they should be in the mix in conversation to find out how they could fill certain gaps. And then, of course, as Anjali talked about too, human service agencies, agencies that provide sometimes sort of defined services to different groups. Could be disability groups, could be health agencies, could be even food delivery and those sorts of things. That's all part of your mobility management mix. Older adult services and organizations, and that could be a different range. It could be direct, you know, just your local senior center, but it could also be a dementia or Alzheimer's program in your area, or even programs that provide assisted living type services should be part of that mix and discussion. Veteran services, as we're going to hear more of today. And in certain areas, if you have tribal entities nearby, of course, the tribal entities should be part of the discussion in that mix for planning. I added local foundations. A lot of times local foundations have people but they also have money, funding and different types of programs that could be advantageous as you plan services. And then, of course, the local and regional planning organizations, and it could be transportation planning organizations, but it could also be health planning, and it could also be planning for other kinds of services, but they should be around in discussions. And then we like to always say, if you got major employers or people needing employees that have need rides to work, they should be part of that discussion. So these are all partners that that you want to try to include as you start bringing people together. But what do these partners bring to your table? They can bring you information and add to your inventory of available services. They can provide you with a lot of knowledge on customer needs for rides, who needs what, when, and where. Something really important. They have expertise on particular rider populations, and the point is, certain groups and individuals can tell you what types of services they need, even the kinds of levels of assistance or what they need as far as at different meeting points and transfer points for different rides. You want these organizations to be there to make sure that your services meets the needs of individuals, and they can bring strategies and perspectives to meet those needs in a way that's workable. But a real key point to all of this is that when you have different groups coming together and different individuals coming together, you get a diversity in viewpoints, which will make your work in coordination and mobility management much stronger. And partners work together because they can plan for identifying gaps and the needs for those riders. Like I said, as you get information, find those needs, and as people work together, you're getting data even around unmet needs. So you kind of know where services need to be provided that you're not providing, and coming up with information and data as to what's the best way to provide those services. And I would say you would provide those through a created a plan of shared solutions by working together. And putting these things together, it's really a coordinated effort, and you can have a one point or call center where you can put together solutions for mobility so people can get rides. So a call center would be a place a customer can call, but also organizations can contact to put their resources sort of into the mix for travel. And then by partners working together, you can also work on such things such as travel training, where that means getting people familiar with using different transportation and transit options. And sometimes you can work on accessibility assessments, within the community or within the travel route itself. And as people get together, you could plan routes for the different transportation options you have. So these partnerships, as you work together, it all results in coordinated service. And that's what really is the end goal in mobility management. So you support and supplement your transportation services by expanding the number of providers available. So you have more rides, you have regional connections to get people to places even outside your usual, say, county or city. You can go to the nearby county, or you go several counties over to get trips into different areas or into large metropolitan areas. And all this effort together creates a structure for effective and efficient services, so that people get more rides, like I said before. And through all this effort of working together, there's innovation. And, if I can say it one more time and end it again, I mean, the goal in mobility management is more rides for more people. So I want to kind of end on that note. So, just to think of mobility management as a way to get more rides. And my last slide is just the National Aging and Disability Transportation Center slide. You can go to our website, www.nadtc.org, get more information for all things, around transportation for people. And, hopefully you can look around for some of our resources. With that, I want to now introduce Mark Chevalier, who is the National Program Coordinator for Veterans Transportation Services. He has an MSW and is a native of Texas, and he earned his Master's of Social Work from the University of Texas, Austin. Mark has an extensive career in the practice of social work and is a veteran of the U.S. Army and the Army Reserves. And really, he was a key voice on kind of working the sort of coordinated service and mobility management types of transportation services around the VA center. So, Mark, welcome.
Thank you, Ken. I appreciate it, sir. Good afternoon, everybody. And I'll go ahead and share my slides now. Let's see. I do see in the attendance some of my colleagues from the VA, some of our mobility managers, Joseph and Toma and Mrs. Derflinger in Black Hills, and we've got a couple of one of my team members, Matt Byers, participating, and a couple of my dear friends from 4-H, Kristen Wing and Maura Tim. So thank you all. Pleasure to be with all of you. Let's see. Start the video. Okay. Let me know when you can see the slide, please. Okay, it's up. Okay, we're going to run through the program that we have here with the VA and Veteran Transportation Program. We actually manage 3 business lines, and it's important to understand this because the mobility managers that we have located at each of the 142 VA medical centers across the nation, including Alaska, Hawaii, and Puerto Rico. They are responsible for managing all 3 of these programs and soon to be a 4th program, a rideshare program. But for now, they're responsible for these 3. The beneficiary travel program, many of you are familiar with. It reimburses mileage for private vehicle transports they make themselves, they drive themselves, or a family member does to VA appointments, either at the VA medical center or in the community. We reimburse for common carrier, which is taxi, subway, train, ferry, boat, air. We also, when there's a medical justification, provide special mode, which is wheelchair, ambulator, ambulance, through VA contracted vendors. Now, for the special mode, well, for all beneficiary travel, there's some eligibility criteria. The veterans have to be 30% or greater service-connected disabled, or they have to have an income below the pension threshold. And there's a couple of other criteria as well that are pretty few and far between, but do exist. For special mode, there also has to be a medical condition that a medical provider identifies and prescribes the transport as a wheelchair, ambulator, or ambulance. Now, in the Highly Rural Transportation Grant Program, that's a program that came about with the Caregivers Act, and it currently is only operational at 14 states, I think, and 22 grantees, 11 states, I'm sorry. And it's very limited because the criteria, the eligibility, is not directed at the veterans themselves. It's rather geographical. And that is that it's only available to veterans living in counties that have a population of 7 persons per square mile or less. And the grants can only be given to veteran service organizations like American Legion or DAV or VFW, and our state transportation agencies. And if given to a state transportation agency, that organization can subcontract with another provider to provide transports. So what we find is that currently, with that criteria, the 11 states are generally from the middle of America west, and predominantly in the western states, where population is much less dense. Now, we have submitted legislative proposals for several years now, requesting a change in the eligibility criteria that would change the highway rule definition to a record code definition, and would increase eligibility to all 50 states and 702 counties, and would allow us to additionally provide grants not only to BSOs and state veterans agencies, but also to tribal transportation organizations. As a result of that effort, Congress saw fit to give the requested $10 million extra to the Office of Rural Health for this program, which is good because we're great partners with them. However, they did not see fit to change the eligibility criteria. So I posed a question to our general counsel to try to get some feedback that by virtue of funding the proposal, legislative proposal, and did they also, was the intent for those funds to be spent on the expanded eligibility? And I'm still awaiting an answer on that, but I anticipate an answer soon. So hopefully it'll come back positive that we can expand the eligibility and transport a lot more veterans in rural areas. Now, we also have the Veterans Transportation Service. It started out as a pilot with 4 sites back in 2010, and now is operational at 122 VA medical centers. And it has been a voluntary program. And so it's grown by virtue of demonstrating its value. And so we anticipate that will continue. And there are some other factors at work within the VA, and some of them were legislatively precipitated that I think will accelerate the growth to the remaining 20 stations that have not chosen to participate to date. But VTS is unique. We have special statutory or separate statutory authority via Public Law 112-260, and it permits the Secretary to transport veterans and others to and from VA and other facilities for examination, care, treatment, rehabilitation, and counseling. So it's a pretty broad statute. We do have regulations because of that broadness. And, regulations change over time, and we anticipate a change in those regulations, a modification coming up in the next year or two. And so with that, we're able to serve any veteran and transport them to any medical appointment at a VA or at a community care appointment. And we have purchased over the years over 1,600 ADA compliant wheelchair vehicles. Sometimes some buses, or also had some wheelchair capacity. But mostly we're focusing on smaller vehicles now. And I guess last fiscal year, FY22, we made over 740,000 transports of veterans to and from appointments. Also, for the last 4 years or so, we've seen an accelerated growth in VA operated ambulance services. Currently, we're funding 12, and I have requests from about another 12 for funding, but I don't have the funding for them as yet. I think I may get some for some of the sites before the end of this fiscal year, but right now I'm out of money for those. But we already had 30 existing programs between VTP and VA Fire Department. So one of the things that has begun is that we are collaborating with the Office of VHA Clinical Services, and particularly the Office of Emergency Medicine, to develop some national standards of care and protocols and standard operating procedures for all VA ambulance services nationwide, because it is a rapidly growing trend that began, or really accelerated, didn't begin, but accelerated during the COVID emergency, when a lot of ambulance providers were going out of business, finding it difficult to meet the demand. So anyway, that's the overall view of VTP. And as I said at the beginning, our mobility managers supervise a number of individuals. They supervise drivers, they supervise dispatchers, they supervise transportation assistants who use a system to reimburse mileage. They also review vendors' claims that come in through contracts and reconcile those claims and process them for payment. So it's a very, very busy, highly responsible job. And among those other things, they also coordinate with local providers when they have the time. To be quite honest with you, and some of you who are part of the team that are on the call, other than an emergency room physician or emergency room nurse during a hot time of busyness, I think that the mobility manager's job is probably one of the busiest in VA, is one of the busiest and most stressful jobs out there. It takes a very special person with very excellent management skills and coping skills to be able to deal with the stress, keep focused, and juggle a lot of responsibilities at the same time. So anyway, I'm going to run through a couple of these slides just to kind of recoup some of what I've shared, so that you don't, so I don't miss anything. One thing I have not talked about, which I'm very proud of and very thankful for, is that ever since, well, before 2014, but it was made official in 2014 with an MOU, the first MOU. We've had a partnership with the Office of Rural Health, and they have been, probably in my whole work career, have been probably the best partnership that I've ever been involved in. I've been working since 1969 full time, and while I was finishing my senior year at Trinity University in San Antonio, and got my master's in 72. And so I've had a long career and I've worked in a lot of different environments in mental health and with the state of Texas, private business. So there's, and that's just to say that partnership with the Rural Health Office of Rural Health has been absolutely fabulous. They're remarkable individuals, and we've accomplished a lot. So they've been very gracious and very generous, and have enabled us to expand the VTS program in rural VA medical centers tremendously. And without them, the VTS and VTP program would not have been nearly as successful as we have been. So just want to share those kudos for Mara and Kristen and all the others, Kelly, Laura, and Lewis, and all the others that we've worked with over the period of time. Anyway, I'm going to run through these real quick. One thing that we are initiating, I referenced it earlier. Our team worked with the VHA Office of Innovation starting about 1.5 years ago. And for the last 9 months, we've been operating a pilot in what we call a VISN, which is like a region. Each VISN contains anywhere from 5 to 9 VA medical centers. And that VISN or network has a network director. So we've been working in VISNs 9 and 15, which is in the Tennessee and Kentucky and area, and then over toward Missouri and St. Louis, that whole area, with piloting a rideshare connection for beneficiary travel eligible only veterans with Uber Health. And we found some things that we suspected were true, were confirmed. That rideshare currently is not really available in rural areas, for one thing. It works pretty well in some metropolitan areas, but it's not very well in rural areas. We found some issues that have developed with rideshare that we have not had with as profoundly with contracted vendor transports, or certainly with our VTS transports, since they are VA employees driving VA vehicles in VTS. But what we found in rideshare is that we see it's a small percentage, but there's a consistent percentage of complaints from veterans that their rideshare driver was late in picking them up, delivered them to the wrong address, or delivered them late to their appointment. Those 3 things in particular. So that's something that we've been working on with Uber Health, and we've had some communication with Lyft. We're going to be consolidating some of our efforts with rideshare, and in doing that, when I say consolidating the management, and at the same time expanding the services to 8 additional VISNs starting on April the 1st. So we will be expanding the service, and then by the end of the calendar year, we'll have the service available in all VA medical centers across the nation. And of course, it's going to be dependent upon the availability of rideshare drivers in each location as to the volume and nature and success of the rideshare pilot. We will be making some other management changes as we roll this out. We currently have a system called VetRide. VetRide is a ride scheduling system. It's data reporting. It also is a budgetary system. We have the sites load up their budget request and vehicle request, and we go through and review those requests and approve or deny based upon performance and other factors. VetRide system also has a third-party portal. We can load up vendors' contracts into that third-party portal, all the particulars of each contract. And when we have a particular ride that BTS cannot perform, we go to that third-party portal. We plug in the veteran's basic identifying information and the pickup location and destination. And the third-party portal will calculate the cost and time of the trip for each vendor based upon the terms of the contract that we have with each vendor. And so we select the least costly, and we send an electronic trip request to the vendor. They then receive that request. It has the pre-calculated cost on it, the pickup and destination locations, and the time of arrival that is required for the veteran at the destination. They can either accept or reject. If they accept, then we send them immediately, like the system sends them a QR code that they can, the dispatcher or the vendor can share with the driver. The driver opens on a smartphone. We can then track that trip, know when the veteran boards, when he disembarks and the trip is completed. It also notifies the dispatcher. They can then go in and complete an online HCFA 1500 and hit submit, and the claim comes immediately back to us for processing. It's a very slick system and it works very well. We use it also for our ambulance program. We have an electronic ambulance portal, electronic ambulance patient report. Mr. Byers, who's on this call, is one of the architects of that, and they've developed a really excellent system, and it allows for paramedics to use a tough tablet in the back of the ambulance while they're in transport to document the patient's condition, any treatments provided, and then when they deliver the patient to the ED, they can provide, if it's a community ED, they can provide a QR code, and the community ED has 2 hours to scan that QR code and obtain that electronic patient report. And for the VA, then they will be able to electronically transmit it into the veteran's health care record at the VA when they return. So a lot of advancements going forward, and we're pretty excited about it. It's keeping everybody busy. I do believe that as we move forward, just like with the rideshare pilot that we now see as beneficial and expanding, I do believe that there will be other opportunities similar to that to partner with community transit organizations, as well as I wouldn't say, I don't know about private, because that's private is going to have to be a contract, but I do see that we will be moving more into community partnerships rather than continually investing in vehicle infrastructures and driver salaries. So, Ken, that's it for me.
All right, thank you, Mark. That's some good information, good detail. And I think really explains to people really what that program is and, you know, what kind of work, and I think in good detail goes into it to ensure that veterans get the rides that they need. All right. We'll move on to Kristen.
So thank you so much. So now we will have Ms. Kristen Wing, who is the Supervisory Health System Specialist with the Department of Veterans Affairs Office of Rural Health. She's been with the VA for over 20 years and has more than 30 years of marketing, promotion, and dissemination of and implementation in public health care and private technology, manufacturing, and the service sectors. Lots of experience. Ms. Wing serves as the Vision 1 Rural Consultant covering the 6 New England states and is the principal investigator for the ORH Veterans Transportation Services Best Practices Innovation Project. As a behavioral and social scientist, Ms. Wing has combined her background in commercial marketing and advertising with health communication theories to translate and disseminate scientific and health-related information to reach diverse audiences. Ms. Wing has led several national projects, including ORH's Rural Clergy Training Program, Promising Practices, and won Veterans Health Administration's Communications Award for her integrated health marketing campaigns. Her current work in the VA New England healthcare system is focused on engaging internal and external transportation stakeholders to increase rural veteran access to VA and community health care in order to address unmet social needs and improve health outcomes through VA community partner engagement and collaboration. Thank you.
Hi, good afternoon, everyone. Oh. Nellie, can you start my video?
I can.
Great. Well, I'm very excited to be here, and I'd like to say thank you so much to our new friends at the National Rural Transit Assistance Program. It's a real pleasure to be here today and to really bring everyone together that we know we really like to work with to be able to increase access to care for veterans by improving the capacity for transportation. So thank you very much for the introduction. I'd also like to acknowledge all of my VA colleagues today, especially our Veterans Transportation Service, Veterans Transportation Program, which includes our DAV and voluntary service, all of our travel departments, whatever you'd like to call it, so our beneficiary travel clerks, coordinators, administrators, dispatchers, everyone that helps move veterans. So what I'm going to talk about briefly today is it's an assessment that we did, not because we wanted to find out what was going on with our Office of Rural Health enterprise-wide initiative, Veteran Transportation Service Partnership, but really just to kind of get a sense of the state of the program, because it had been in operation for several years. A lot of different policies, new programs, as Mark had mentioned, had come down. We wanted to make sure that we were truly taking a good look at the program a couple years into it to make sure that we were addressing the needs and not just of the veterans, but also of the program as time had gone by. And I have to also say, we could not have done this, certainly. And it sounds like a bit of a love fest with our friends, Mark and everyone in VTS, but we have absolutely had a fantastic partnership in being able to do this project, this study, to really do an assessment. We worked with 41 different rural VA medical center VTS sites, talked to Veterans Transportation Service mobility managers and coordinators who were very open and honest. And coincidentally, when we talked about doing this, it was pre-COVID. We had just known the program had been in operation, had been very popular and very successful for many years. We had no idea what we were going to be looking at in terms of a global pandemic and the new normal and what the new baseline of what transportation could do and what innovation, immediate innovation could do to make sure that transportation was being utilized across the country. So I'd like to give a big shout out to all 41 of our ORH funded VTS sites and all the staff, because what we're talking about today are really your words. So some of the key takeaways that we found was that, and this is really important for all of our friends in the community transportation and transit organizations to take away. Veterans can easily access transportation services if they're available at their local medical center by contacting the local VA medical center directly. As part of our project, we conducted what was a veteran experience and investigation as part of our learning about the program, what transportation services were available. So I have to give tremendous kudos to my Veterans Transportation Service Study team, especially Mr. Paul Boucher, a veteran himself, who conducted the majority of these interviews and was able to connect with the mobility managers and transportation coordinators in a way unlike anyone else, I believe, really truly could. And that's a theme that we find throughout our VA services, is the veteran connections. So Paul was able to connect to the different people at VTS by dialing into the VA switchboard telephone number that has been advertised on the internet. In Yellow Pages, if you still have one, it can be accessed fairly easily, and had a very, very good success rate on getting in just by mentioning to the switchboard operator that I'm a veteran in need of transportation to a medical appointment. And calls were transferred either to the VTS or the DAV voluntary service, or to someone in a travel department, beneficiary travel, on 98% of our calls in the first attempt. The other big takeaway that we found, and of course, again, this was in the midst of COVID, was a tremendous stress on the system and capacity due to turnover due to retirement. A lot of people during COVID decided to retire at all levels of VA. People choosing no longer to work if they didn't have the option to telework because you can't drive someone from a computer. And that there were, particularly in our volunteers who were a little bit older, that there were health concerns, health risks being exposed in small spaces. And so that really impacted the overall capacity of transportation by not having a pool of transportation volunteers and the normal pool of employees, and then folks opting to move into other positions because as there was turnover, they opened up. And then recruitment and retention in rural areas is very difficult, and it's also very competitive when there are jobs locally that are open, that are at a competitive pay rate. More likely, people in rural areas will take those versus coming into VA. So definitely hiring and training needs are a priority, and I think that's something that we definitely share in common. Another huge takeaway from this program is that VTS provides more than just a ride. This is one of the most emotional components of this whole program, and anyone involved in transportation knows this. Drivers provide more than a ride. We have heard time and again about the connection, the peer support that veterans have. A driver and a rider, it's a relationship. And for those that are rural and remote, are isolated socially, either due to geographical issues, but also technological issues. Not everyone has access to the internet, and we're able to Zoom call or connect to telemental health through a local VA provider during COVID. So having that connection, really, we are seeing how transportation is a social determinant of health and has a direct impact on health and well-being for everyone. Can't stress the veteran connection enough. And I say, as a federal government, generally hire about 32% of veterans across federal agencies as our employees. But the VTS and Veteran Transportation Program are far and away probably what I consider a veteran-owned veteran-operated entity within the VA. You can see here representation from all the services. And this veteran experience, this camaraderie, an understanding of shared mission, logistics, transportation, scheduling, personnel, all of that they bring is such a unique skill set that we have in VA, and specifically in the transportation program. Part of this, again, is the above and beyond commitment to serving veterans. And you know, there are so many puns in transportation about, you know, hitting the road, where the rubber meets the road. And one of the things we did hear consistently that's just not a cliche, but is literal, is going the extra mile to make sure that all veterans in need of a ride were getting to appointments, whether it's at a VA facility or at a VA approved community provider, making sure that veterans got where they needed to go to get the care that they needed. Well, I'd like to come back to one of the things that Ken had mentioned too, and this is shared solutions. And one of the really great findings that we had in terms of our best practices is that where some locations were finding challenges, other locations had overcome them and had fantastic solutions to put them in place. And that's one of the things we're going to explore more this year in Visit One in New England, is how we can help local VTS programs and all of the stakeholders there put these best practices in place. Obviously, engagement, not just with our veterans, because for the VTS program, it's actually what I consider a victim of its own popularity. The word of mouth about the program has surpassed any need for printed materials or social media engagement. Veterans talk about the program, and providers know about the program and make referrals whenever they know that there will be a transportation need for a veteran to be able to get to an appointment and maintain their care. So definitely engagement, local in our facilities, with our transportation programs internally, as Mark mentioned, the different rideshare programs, ambulance services, all kinds of different opportunities for transportation. We want to make sure that there's a collaboration and coordination, not just within the transportation programs, but you know, to best practice number 4, within the coordination within also clinical services. We know our social workers and a lot of our medical support folks that are at the front lines, that are checking veterans in, checking veterans out, that are discussing other social needs with them, have a capacity to really be that central coordination point to make sure veterans' needs are being met, both their health needs and then other social needs. Stationing vehicles at remote locations, we found can potentially help capacity, but then that's also a resource issue. You need more drivers and more vehicles. And even if vehicles are available, again, hiring, recruitment, retention issues in rural areas make it a challenge to put someone in that vehicle to transport them, those veterans in that more concentrated area close to what we call, CBOC, a community-based outpatient clinic. I mentioned the clinical documentation of transportation need. That's something that our innovation team, we've gone from being the Veterans Transportation Service best practices study to being an innovation where we really wanted to do a deeper dissemination and implementation investigation into the how. How do we make these things happen? We know the what, we know what is working, we know what is good, but how can we make this happen and help facilitate at all levels to put these best practices in place across the system. And so this year, our innovation team is joined by an emergency physician, Dr. Zachary Hahn, a VA main healthcare system, and then also Ms. Kathy Marchant-Miros, a research nurse. So we're going to really take a deeper focus and look at transportation in terms of the impact it can have on health outcomes. We know that no-shows are issues for healthcare, both VA and non-VA. And can we utilize transportation proactively to address no-show issues if we see a pattern? Certainly. And one of the things we want to look at is a pattern, particularly in mental health. We're always cognizant within VA and making sure that No veteran is not aware that we're available to them if they need help, if they're in crisis. And of course, our best practices of being staffed by veterans, because if they are in crisis, they may feel more comfortable opening up to someone on the 3.5-hour ride from a very rural clinic to an urban facility for some kind of specialty care. Oh, and that's it for me.
Thank you so much, Kristen, for sharing that information, and your care for the work that you do really comes through. So next we have Frank Thomas. Frank is a certified community transit manager and a graduate of the paratransit transit management program of the Graziadio School of Business Management at Pepperdine University. He is the regional coordinator for the Oregon Department of Transportation's 5th region, the 8 rural counties and 2 tribes that comprise the eastern third of the state. Frank has previously served on the National Rural Transportation Assistance Program Review Board and remains a passionate supporter and brand ambassador to this day. We can't let him go. He recently entered his 25th year of service to the rural public transit industry and is a member of the military family.
Okay, is my screen up? Can everybody see me?
Yes.
Fantastic. Hi, my name is Frank Thomas. I am now the Transit Network Program Manager for ODOT Public Transportation Division. In addition to my day job, it's been my privilege to serve on the development committee that delivered Oregon's innovative Rural Veterans Healthcare Transportation Grant Program. And I'm super grateful for the opportunity to share some of our work today. Our story starts in 2012 when ODOT Public Transportation Division administered a small veterans mobility research project. 2 of the participants I'm going to share with you today, Rogue Valley Transportation District and Central Oregon Intergovernmental Council, were part of that original effort. In 2014, the Veterans Choice Act was signed into law, which created, amongst other things, the Highly Rural Veterans Transportation Program. In 2015, Oregon became a highly rural veterans transportation pilot state, and it has been a runaway success ever since. During our first biennium, Oregon accounted for over half of the highly rural service miles nationwide. In the second biennium, thanks largely to a set of strong startups in Alaska, we delivered a plurality of those miles, so it's down to like 40%. But last summer, we rolled over the 2 million mile mark in delivery of highly rural service for veterans. Highly rural funding is never sufficient. Most of the programs in Oregon are operating off of local resources for at least 6 months out of every biennium. None of those providers have historically suspended or rationed service. They just keep finding a way to make those numbers work. The Highly Rural program created an unintentional divide between access haves and access have-nots. I'm going to give you an example of Union and Baker counties, who are neighbors in Eastern Oregon. Union County has about 9,000 more people and critically about 1,000 fewer square miles. Those quirks of population and geography meant that it was ineligible for the highly rural program enjoyed by Baker County, even though their veterans populations, healthcare resources, and access needs were virtually identical. In 2019, Oregon's Legislative Assembly provided the Oregon Department of Veterans Affairs with a $500,000 one-time investment to demonstrate a more equitable approach. ODVA invited us to partner, and the next thing we knew, we were rolling out this game-changing solicitation just as the global contagion was disrupting both the healthcare and public transit industries. In retrospect, it was actually a pretty good time to learn about what works and what doesn't. In any case, 10 new rural projects turned in an exceptionally strong pilot. On an annualized basis, they delivered 30% more rides than their more mature, highly rural peers. Their average cost per ride came in about 48 cents higher, and that may seem counterintuitive, but that wasn't really all that bad for startups launching into the teeth of a global pandemic. In July 2021, the Oregon legislative session passed House Bill 2139, which formalized our Rural Veterans Healthcare Transportation Grant Program in statute and boosted the total program budget from $500,000 to $650,000 per biennium. We're running a little behind, so I'm going to move through these next few slides really quickly. I suspect I'm preaching to the converted, so it may be kind of a distinction without a difference. The highly rural veterans population accounts for approximately 1 out of every 100 veterans enrolled in services through the U.S. Department of Veterans Affairs. When Oregon made its investment and expanded to take on rural markets, in addition to those that are highly rural, our service population grew to approximately 33 out of every 100 enrolled veterans. Like the rest of America, veterans are aging really quickly. In the upcoming federal fiscal year, the largest age cohort being served by Veterans Affairs at the national level is projected to be between 75 and 79 years of age. 5 years later, here's what that looks like. And in 10 years, the leading edge of the generation who said, never trust anybody over 30, will have attained the highest age bracket we've got. At nearly 1.7 million members, they're still going to be our largest service contingent. What I want you to take away from this slide quickly is that all of the top 10 conditions presently being treated by the federal VA are chronic. These are not one and done visits. A couple of these conditions may stand out for some of you. Chronic ischemic heart condition or heart disease and pulmonary disease are examples of ambulatory care sensitive conditions. Those are conditions that make a veteran highly susceptible to an otherwise preventable hospitalization when he or she doesn't receive follow-up outpatient treatment. For highly rural and rural veterans, distance is a deal-breaking, mission-critical, significant barrier. It was the most prominently cited barrier in the 2019 poll by the Wounded Warriors Project that found up to 30% of respondents had opted out of the VA care system. Why? Because it's just too far for me to get to care. So some of the key elements of our rural expansion partnership with the Oregon Department of Veterans Affairs were, we took a super broad look at eligibility. I'm not an expert on the federal service thresholds that constitute what is and what is not a veteran, but ODVA and Public Transportation Division settled on Oregon Revised Statute 488225, which you don't have to know. It's a completely unrelated eligibility profile for veterans' preference in public employment. Why did we choose that when it doesn't relate to transit or healthcare? Because it was the most broad and inclusive citation that we could find. All of Oregon's federally recognized tribes, irrespective of rurality, are categorically eligible to participate in our program. And this part is really important. The Rural Veterans Program we built also recognizes that tribal communities aren't limited by geography. A veteran who lives in downtown Portland, Oregon, but is a member of a tribe that has accepted a rural veterans healthcare transportation grant has the right to receive services through his or her own tribe. And the funding for that service, the expenses of that service are fully reimbursable under Oregon's funding model. In program development, we work with veterans, veteran services officers, and tribal VSOs, veteran services organizations, and stakeholders in healthcare and community services in order to maximize the flexibility and choice on what defines healthcare. We chose to focus on access to goods and services that generally contribute to a veteran's well-being. And that had the effect of positioning our transit providers to say yes to veterans whenever the logistics allowed. Examples of what we were looking at and what I'm talking about here include, but aren't limited to, community and walk-in clinics, including those that are staffed by a nurse practitioner. I mean, primarily run by a nurse practitioner. You don't necessarily have to have a licensed physician on staff. Pharmacies and durable medical equipment, vision services, including vision retailers, dentists and denturists, audiologists, hearing clinics, physical or occupational therapists, smoking cessation and weight loss services, palliative care, and this one I really liked, alternative or culturally indicated appropriate medical services. A veteran can also take advantage of other co-located retail opportunities while they're getting their medical stuff done. For example, while filling a prescription at a big box retailer, if he or she wants to, they're welcome, even encouraged, to do some shopping at the same time. We call that trip chain efficiency in Oregon. So Rural Veterans was also built on intentional and ongoing input from our stakeholders. During the pilot cycle, we formed a steering committee, which was comprised of veterans and their advocates and healthcare professionals. And we asked them to score applications and help us select projects after they'd helped us build what the project or what the service was going to look like. That practice went so well that it stuck. The steering committee has since become an invaluable resource. When a program manager in Salem, like me, is trying to solve a challenge in a local rural market or respond to an opportunity, an expert who knows the local conditions and is familiar with our work is usually just one phone call away. In the pilot cycle, rural veterans benefited from the input of Oregon's very first tribal veteran services officer with the Confederated Tribes of the Umatilla Indian Reservation, which is probably the most forward-thinking tribal transit system east of the Mississippi or west of the Mississippi. In the second round, a VSO from our Warm Springs tribe served throughout the development and delivery of the entire project. During the second round, we also recognized that we needed to help our recipients with outreach and engagement. Public Transportation Division developed a partnership with Rogue Valley Transportation District's Go Vets program to provide technical assistance and support for every single rural veterans recipient that we had. That has proven to be specifically advantageous as we're trying to emerge from the pandemic. Finally, in the second round of funding under House Bill 2139, eligibility for resources was expanded to include Oregon's original highly rural jurisdictions. And that turned out to be a game changer. In addition to providing highly rural programs with the supplemental resource they need to get them through a biennium, it introduced their programs to all of the flexibility improvements that we've just covered. So Jefferson County, that's these folks right here, was the original Veterans Healthcare Transportation recipient grant recipient in the pilot cycle in Central Oregon. Their partnership with Central Oregon Intergovernmental Council helped position them to consistently deliver over 500 trips per quarter. COIC also brought with them its dedication to public engagement. They delivered over 40 events, engaging 227 unique veterans, all within the evolving pandemic safety protocols. In the second funding round, COIC leveraged its initial success into a larger partnership that integrated Crook County here, Deschutes County, and this little blue dot here, which is the Confederated Tribes of the Warm Springs Indian Reservations of Oregon. As mentioned previously, the Warm Spring tribes were an early adopter of ODVA's efforts to grow access to VSO services and VA benefits through culturally sensitive, trusted tribal representation. The Rural Veteran Steering Committee was fortunate to have Ramona Cannell involved in the initial rulemaking all the way through development and delivery of that second cycle. Active engagement by an underserved population can't be discounted in COIC's growth story. The partners here are presently on track to double COIC's first cycle ridership and deliver on basically 53%, over half of all the rural veteran revenue miles delivered in the entire state. COIC is now exploring cooperation connections with Basin Transit in Klamath County, that's down here. In 2022, Basin Transit expanded its rural veterans program to create out-of-district services, including coordination with the Klamath tribes that creates new access options to care in Central Oregon's more densely populated markets. In early 2023, in fact, it just got done on Friday, March of 2023, the Public Transportation Division, that's my shop, infused another $180,000 in pandemic-related support for COIC's veteran programming. In the upcoming statewide Transportation Improvement Fund cycle, the rural counties in the COIC partnership have even stipulated that the Rural Veterans Program will be an eligible recipient of some of their really precious formula dollars for ongoing growth and sustainability. Access to those resources could begin as early as July 1st, 2023. Rogue Valley Transportation District's initial groundbreaking idea for Go Vets was about the consistent outreach necessary to build a relationship with the local veteran community. The program itself is led by Brian Simpson, who is himself a veteran and an active member of the Oregon National Guard. The Go Vets program engages veterans often through other veterans. That's their first line of communication whenever possible. Veteran services officers, medical clinics that treat veterans, veteran services and support organizations and nonprofits, and allied professionals in the healthcare industry. It provides essential resources, information, and passenger support to make public transit a viable option for most trips. Professionally designed and constantly refined outreach materials in print and digital complement a thoughtful, well-designed swag bag sort of branding approach. Everything in the Go Vets Welcome Kit has a role in resolving the most commonly cited barriers to public transit use. We're talking about things like easy to understand waterproof maps, large print materials with a phone number for a live mobility manager, not a recording, not I got to punch 7 buttons to talk to somebody, but an honest to goodness mobility manager at RVTD. They've even got earplugs to help filter away the noise and commotion of a public transit system while preserving enough sound to feel alert and safe. They've got a lot more in here than I have time to cover, but it's all hand delivered by a knowledgeable professional who's eager to serve that veteran, even if that means helping him or her on a non-public transit service to get where he or she needs to go. Go Vets approaches veterans as passengers to be served, not problems to be solved. Noticing how Go Vets had inspired imitation around the neighborhood where RVTD does business, we actually engaged them in a support contract on behalf of our funded subrecipients. Brian is essentially franchising out everything that's made RVTD successful so that our recipients don't have to reinvent their highly functioning wheel. In addition to Brian's technical assistance, we funded a collaboration with one of our outreach and media contract partners. We're going to put at least 2 sponsored news stories, which are presently included in our current agreement, for publication in magazines or other periodicals with a broad veterans audience. Those stories will build awareness of the program and its benefits, offer good news on milestones and performance metrics, share testimonial accounts from veterans whose lives have been impacted and improved by this service, and hopefully build continued support for ongoing investment. I've got these really fun snapshots of local awareness building and know where to use them. So I'm dropping them here while I cover the last few takeaways that we learned from a couple of years of trying to emulate the Go Vets program. Whenever possible, having veterans communicate with veterans is absolutely key. The next best thing, and it's kind of a far second distant, is trusted ambassadors such as VSOs or caseworkers in the clinics where veterans receive care. Beyond that, these 3 crucial practices stood out for us. 1, we got to show up at veterans events, especially when we don't have anything specific to share with them. One of the criticisms that we got early on went something like, you guys only show up when you want something from us, you want us to support something you're working on, or you've got something to sell us. Ouch, but perhaps not unearned. Attending in with our mouths shut and our ears open is sometimes the best way to figure out how to contribute to emerging opportunities for veterans while we're building those critical relationships. Number 2, the trust of our veterans who use our services can be highly fragile. It takes persistence and work to earn their confidence. There has often, at least in Oregon, been a history of new services running into resource challenges just as they're gaining traction. And that's resulted in a certain skepticism that only time and performance on our part can overcome. When you're investing in transportation services for veterans, you're in it for the long haul. It pays to think about contingency resources and partnerships accordingly. 3, engaging local healthcare providers in veteran-centered partnerships will consistently pay dividends. Can your mobility managers name your VSO or any of your VSOs? How about one or more of your local hospital's discharge planners? Do they work with caseworkers and appointment staff at local clinics to promote your services and to help passengers coordinate scheduling? If so, you're well on your way. If not, these might be relationships that will benefit from some intentional efforts within your own community. Speaking of engagement, in terms of emerging opportunities, we're finding significant untapped value in working with multidisciplinary teams. Those are local groups of technical and often non-technical contributors who coordinate on effective approaches and problem solving for people they're trying to mutually serve. Your mobility managers often have an essential role to play, especially in wraparound care and outpatient services planning, outpatient success planning. But all too often, they're the people who should be at the table and simply aren't. So here's a quick and dirty self-assessment for my transit manager friends out there. Who on your staff engages healthcare and human services professionals in a regular set of recurring meetings? Who are your community's key influencers and decision makers for healthcare and human services? Who in your community might have reliable support or in-kind resources to offer around human services and healthcare access? What are your community's top 2 or 3 unmet access needs or unrealized opportunities around healthcare and human services? What are you doing to make sure that transit is engaged in those conversations? How's that working out for you? And how do you know how well it's working out for you? If you've got an off the top of your head answer for 4 or more of those questions, I'm really looking forward to attending your next presentation with our friends at National RTAP. If you're like the rest of us, it may indicate that there's an opportunity to start a coordination conversation around veterans that can inform and improve several other of the objectives in your community that you're trying to work toward. Better integrating public transit experts into coordinated care organizations, community action agencies, human service organizations, and nonprofits serving veterans is one of the most promising and emerging opportunities identified by this effort. I don't really have a good ending for this, but I've almost got us caught back up on time, so that's a positive. Thank you very much for your time and your attention. What I want to leave you with more than anything else is that Oregon has done everything that we've delivered in the last few years on the cheap. And that means it's highly replicatable. You can do it. If we can do it, you can probably do it better. And you can probably do something better that I'm going to want to replicate and steal blind when I hear it coming from you. Here's a few links to resources that I mentioned during this presentation. And I think I got us caught up. We can hear from Heather. And afterward, I will welcome your questions and comments. Please do keep those cards and emails coming. I can talk about this literally all day. Thank you for the opportunity.
Thank you so much, Frank. Great tips. Now we are running a little bit out of time. In the chat, we just shared a brief resource that will be updated and a link to the survey so that you can share your input for the next webinar in this series. Next, we have Heather Thomas. Heather joined the Upper Cumberland Human Resource Agency's public transportation team in 2021 as a mobility manager and obtained her certification of travel trainer for mobility and orientation specialist in the following year. Heather served as the 2021 to 2022 National RTAP Community Rides Grant Project Manager. The Empower Upper Cumberland Grant Education Liaison and the Cost Benefit Analysis Team Lead for the Empower Pilot Grant, impacting the Upper Cumberland region as a mobility community liaison started by addressing barriers that has laid the foundation as an integral part of serving the community and creating successful partnership. Ms. Thomas currently serves as the Putnam County Coordinator for UCHRA. Additional leadership roles strengthen her community connection and partnership engagements, serving on multiple organizations, including Ambassador for the Putnam County Chamber of Commerce, the CRMC Charitable Foundation's Coalition for Wellness, Upper Cumberland Youth Workforce Committee member, Circles USA chapter mentor, and Friends of the Animal Shelter fundraising committee member. Thank you so much, Heather.
Thank you for the opportunity to speak today. I appreciate the invitation. And thanks to RTAP Community Rides Grant, hold on one second, I can't talk and share my screen at the same time. Let's see, there it is. Okay. There we go. Okay. Not quite sure. Can everybody see this in the middle of the screen? How do I get rid of that? There
It's working, Heather.
Okay, great. Thank you. Perfect. Okay, so thanks to RTAP and Community Rides Grant, we did start the conversation with our veterans. It was a wonderful opportunity for us to start building those collaborative partnerships. So UCHRA Public Transportation Program logged approximately 2.6 million miles last year and fulfilled over 260,000 trips. We're operated by the Upper Cumberland Human Resource Agency. So I have partners in-house, so it's wonderful. The UCHRA is celebrating 50 years of making a difference through 35 programs focused on improving the quality of life for those living in the Upper Cumberland. Last year, 35 programs provided 1 million units of service through the Community Services Department, the Upper Cumberland Empower, Community Intervention Departments, and Public Transportation. So the Community Services Department that Mr. Thomas also mentioned administers a variety of programs that assist low-income and vulnerable populations here in the Upper Cumberland and around our nation. Empower Upper Cumberland is forged from the collective regional mission to shift children and families out of generational poverty, serving the most vulnerable populations in the 14 counties that we serve. Community Intervention Department provides programs that target opportunities with the community to provide quality of life for those who are at risk with the correctional system. Individuals who are victims of abuse or neglect, and children who are in need of positive learning environments. So it was definitely a privilege to serve as a project manager for the Community Rides Grant. That is where we started building our reliable partnerships. So you've talked today a lot about funding sources, obvious places to start with your veteran clinics and hospitals, the American Legion, Veterans of Foreign War, of which I am the granddaughter, the niece, and the sister of men in my family that served this great country. So we're very passionate about providing our services to our veterans and making sure that they have safe, reliable transportation. So the UCHRA Public Transportation serves 14 rural, 3 of which are not as rural, but we have lots of areas that are very hard to get to, mountainous, lakes, rivers. We got to go all the way around the mountain to get people sometimes. We're situated in between Nashville and Knoxville at the base of the Cumberland Plateau. The UCHRA Central Offices and Transportation Hub is situated 75 miles from Nashville and 55 miles from the Veterans Affairs Hospital. Clearly, our proximity to VA healthcare facilities is a huge barrier. Coordinating transportation and building partnerships to provide access to healthcare takes trust and reliable service. Since we've all heard great information about the complex funding and planning, I hope to just inspire or give a little information about resources in those reliable partnerships that you may have overlooked. Not everyone uses public transportation, but everyone needs to understand its vital importance. That is a phrase that I heard at a transportation conference 2 years ago, and I have used it in many conversations advocating for our riders, to our elected officials, mayors, to senators, to congressmen. Everyone needs to understand the vital importance, and none more important than trips to healthcare for our veterans. Talking to elected officials and partners, make sure that you are advocating the public transportation services that you are providing. And then look at your reliable partnerships, the existing partnerships that you currently have, the connections and relationships that are already in place. Can you deepen those partnerships to also include efforts with our veterans? Reach out and take steps to educate those you already have relationships with about the services that you provide that might help your veterans. We provide, I'll give you an example. We provide the transportation to the local university, which has about 12,000 students. It's Tennessee Technological University. It's a wonderful university. We provide their campus transportation. Many of the faculty, students, and their families have served our country and may not realize that our public transportation gives discounted rates to veterans. Don't miss an opportunity in your area with those higher education facilities to strengthen that existing relationship by educating them on the full spectrum of your services, not just the one you're providing, that loop that you're going around getting those faculty and students to their classes and their buildings. This morning it was 25 degrees here in Cookeville, Tennessee. So I bet there were lots of people jumping on that bus today. So giving some materials, marketing materials, we have billboards, we have social media, all of those things. Take a piece of that and put it on all of your buses. So on our on Tennessee Tech's current contract, we have wonderful flyers. We've empowered our drivers. They talk about the other transportation that we do. We go to Nashville, the 80-mile trip, 3 times a day from Cookeville, which is the hub of the 14 counties and where our transportation hub is located. We go there 3 times a day. And we go daily from McMinnville, one of the other larger one of the 3 large one-tier counties in our region. We do that daily as well. So that's going directly to the medical VA facility there in Murfreesboro. So don't miss an opportunity to connect, inform, and advocate for your other services. Access your connections, communicate. How are you building on those relationships while you're creating the partnerships? It takes connections. It takes an introduction. Provide access to healthcare takes all of these things: communication, reliability of service, and strategic resources. Our agency, like many of your organizations or programs, strive to improve the quality of life through a diverse array of services. We connect and provide individuals and families with the resources that they need. When setting out to improve our veterans' access to healthcare, we started by looking inward. I lost my place. I'm sorry. Inward. Okay. In our organization, we have several of our staff and leaders that have served in our military. So we encourage their role in helping us reach other veterans in our community and help us to uncover the unmet needs and broaden that reach to deepen those relationships and partnerships that would strengthen our efforts to serve our veterans. So your personnel is your greatest resource. Empower them. Don't miss an opportunity to strengthen the relationships that we have with our riders by empowering your drivers, your dispatchers, call center specialists, and anyone else in the building. And for us, that is many people. They are our front line and our reliable, the ones that are providing that reliable service. So do share your strategic marketing plan and materials with your personnel, because they're the ones that are in your community, coaching the Little League, playing in the community band, volunteering at the chamber, volunteering at the mission, serving meals in their church. It's that human connection to your individual communities that will serve you the most. So tap into that resource. And don't forget to inform them of new services and provide them that marketing material to hand out. A business card we have found with a QR code on it that links to a new service or an app, or, you know, I know I'm technically challenged, but my mother, my father, everybody in my family can work a picture because we have a cute little great grandchild in my family. So I know if my 78-year-old parents can use a camera, they can use a QR code. It is a wonderful link, and I would encourage you to put it on all of your materials. It will take them right to where they need to be. It's very powerful. So they are the ones that are providing that reliable access to health care. So don't underestimate the power of your driving force. Building connections, trust, and communication starts by listening. So thanks to Community Rides, as I mentioned, we started with rider surveys, focus groups, and moved on to veteran case studies and stakeholder engagements with our leadership for veterans. Build your plan and discover the 5 W's, the who, what, where, when, and why. Who is utilizing your services for veterans? What do they do to gain that access? Where do they need to go? When do they need the transportation? And why are they utilizing your services? or better yet, why are they not utilizing your services? We started our rider surveys to identify the veterans who are using public transportation, their why. We determined their knowledge of our services, discounts, hours, routes, websites, apps. You can best gauge your success and your failures by first listening. After identifying those willing to participate in the focus groups, we did more listening and started building connections to those programs where we felt gaps were there. Services and routes and creating case studies for our grant applications. These are all wonderful tools that'll help you build that partnership. The roundtable that we had, actually thanks to Community Rides, targeted the community leaders, veteran organizations, staff in our organization that are military or have served in our military. And then we basically advocated that connection and the partnerships and building that reliability, trying to figure out collectively how to overcome obstacles and just building that relationship. The UCHRA Transportation Roundtable discussion on transportation options for veterans in healthcare, that group in attendance, we all recognize the military service of those in our agency and the invited partners. We gave an educational presentation about all transportation services, job access, discounts for veterans on the city routes. Major focus was given to the direct access to healthcare in Nashville and Murfreesboro. Like I mentioned before, that we go 3 times a day to Nashville, that 80-mile trip, that's quite expensive, and Nashville traffic is nothing to shake a stick at. So Monday through Friday, we have that Connect I-40 and I-24, and they transport veterans every day to medical facilities. So you have to also remember that there's a feeder trip because we have several coming from the outer counties in those more rural and isolated areas that have to come to the hub to get that bus. So it's an all-day process to get the veterans where they need to go. The veteran relationships require trust. And so if you've tapped into your personnel, many of our drivers have served in our military. They are just gems. We cannot say enough about the precious people that are driving our vans and our buses and serving the public and taking care of our veterans. So you earn that trust by providing that reliable service, and you've got great drivers in place. So empower your personnel to build those connections for you. And as Mr. Thomas also mentioned, in 2021, over 42% of male Americans aged 75 years and older are veterans. So I think in his bracket was 75 to 79. The over 75 male adults in this nation, 42% or more are veterans, and they are the largest population. If you don't cut that off at 79, they are the largest demographic. So what is your agency doing to connect to veterans who are that largest group? I suggest partnering with the Area Agency on Aging and Disabilities, which also help with nutrition and senior citizen activities. There's wonderful transportation opportunities in those facilities as well. We have a senior expo here in Middle Tennessee that draws a population from 20 counties. It's more than 3,000 people in an 8-hour window. It's a great place to advocate, to share your services, but also to network, to build those partnerships. So I'd look into your community events and set up your booth and go and have a meet and greet and take lots and lots of material with you to share. So through our Community Rides grant, the successful partnerships, we had wonderful communication, great connection, and a real sense of community. Representatives from the Tennessee Tech University ROTC program, the Veterans Affairs, 14 county veterans offices, and the VA healthcare systems, as well as representatives from the U.S. Senator's offices were invited to attend that roundtable discussion. That was a huge success. And we assisted them in connecting services that we have as in community services and all of the other under our house. So we have 35 programs, as I mentioned before, that help serve low-income families. So that was a wonderful way to build those relationships, to really surround those low-income military families so that you can help them with emergency crisis needs, whatever's happening there. Share those resources and your data. You don't have to reinvent the wheel. There's great common goals that you'll find that you share with these partners as well. The community services action grant, we every 3 years will do a huge all 14 counties, or well, every agency actually gathers data and has a survey, and you can build that partnership with your community action group and add transportation to that survey, and you'll be able to use the shared efforts and get that data as well. So if you partner with the community action agency that's already building that stability and decreasing homelessness and helps with nutrition related health problems and provides emergency assistance for energy and water, lots of things. So if you're not connected there, you can actually go on their website, acf.hhs.gov/OCS. And you could just type in community service action as well. So I wanted to show you, I know we talked about earlier about a partnership with rideshare. We had a partnership with Uber, but ours is very unique. We were on the Uber app as an option, but it was our driver that has passed the drug test, who has done all the training, hours and hours invested in that driver that provides reliable services. But it's also our van. So it's a really nice van. It has cell phone chargers, and it's really great. This just happens to be one of, it's not a great one because you probably can't read that, but that's just one of the flyers that I could figure out, because I'm technically challenged, how to put in the the slideshow here. But it was a wonderful partnership. It's been highly utilized with our university partners, the healthcare system partners, our job access partners, the veterans groups. But again, the greatest resource is our people. So this flyer was given to all of our partners to then share about this. We also connected with many of the nonprofits in the areas for their fundraisers and provided safe rides and taught them. This is kind of the one that shows you, if you look in the middle, the highlighted Pickup Cookeville, it's $6 when the Uber X was $7.99 or the Uber XL was $10.50. So it's discounted pricing with our contract to provide safe transportation. And it's extended our hours of service when our buses and the office is not open, because everything is done through the Uber app. So it is a wonderful partnership. But make sure you do provide that marketing material to all of your outreach opportunities and your employees. And then again, it was also included in that in a grab bag at the Senior Expo that I mentioned earlier, where we had a huge attendance. So if you can strategically align partners and help them in their roles, advocate and empower them to make those connections, they'll build those relationships for you and help you provide that vital access. So lastly, I guess, to improve access to healthcare for veterans, focus on a deeper relationship. I guess that's my real point of today. You don't have to reinvent the wheel. Do focus on that access. Our call center schedules daily trips, and it's veterans that make those trip arrangements for us. Veterans are going to healthcare are reimbursed for those miles here. We don't have veterans transportation centers like some of the other states that we heard from today. So ours is unique in that. But the partnerships do start with that community connection. And a lot of that can be through your personnel. Building a reliable partnership starts with those existing partnerships and contracts that you already have. Don't forget about that. But also empower your drivers and your staff that have served to advocate in their individual communities. We have probably 20 mayors. We have county and city mayors that are involved with us as a human resource agency. And we take great strides every year to educate everyone involved in our local government, what programs we have, how we can serve the people of the Upper Cumberland, and how we can be a difference maker. But you know, we utilize the Community Rides RTAP grant, which I would encourage you to apply for. It just really has been a game changer for us. It gave us the opportunity to spend marketing dollars to set up booths. We did not have funding for that in our other grants. So it provided resources for us to really reach the targeted vulnerable population, and veterans were among them. So it's been a wonderful privilege to be a part of those focus groups where the veterans showed up and educated us on what we needed to do. And I would encourage you to start those conversations. And then, you know, really empower your veterans that work in your organizations. You know, they can be the leaders to the service access that you might need starting that process, and then coordinating and, you know, the plan and provide the vital connections to healthcare starts really with funding and planning. But none of that matters if you're not making the connection to the veterans, and they require, you know, respect and trust. And so you can get that or faster than a billboard. You can get that through the people that are in their communities that they already know. So don't waste an opportunity to look for, don't miss an opportunity to empower your existing personnel, your existing relationships, the leaderships and veterans that serve in your current connections and contracts as well in the community, because it's on a personal level. Let's see. And don't forget to empower the drivers to get out your marketing materials. They love it when we have something left over for them to give out. We have it in all of our vehicles. We created the QR code, like I was telling you. I wish I could show you the cheat sheet. I couldn't figure out how to do that. But of the 35 programs in the 2 agencies that we have a little QR code and a little description, and I give it to every person that I talk with. So thank you so much for your time. I appreciate the privilege to speak to you today.
Thank you so much, Heather. And I did manage to share a copy of your excellent flyer. And if people want to scan that QR code to get that app, go ahead and do so. If you wanted to speak more about it, are you able to see it better now on my screen? The flyer that you were mentioning?
Yes, thank you.
And here's the QR code, and here's how much it is, the $6. It's pretty clear. It's excellent material.
Thank you.
And so I did want to mention really quickly that we do have a survey, and I've shared this resource document that has materials about customer service, grant writing and management, mobility management, transportation coordination, and transportation to healthcare, and veteran specific information. We'll be adding a couple more links that were mentioned in the presentation and then sharing this again. Please do take our survey. We'll be having a second webinar related to veterans transportation to healthcare. And so we would love your assistance in developing the material for that. So please do take the survey. And now we'll take questions. We have a couple that haven't been answered already, and we'll just go ahead if the panelists would like to come back on. And we'll start with, since CCAM in 2004, there has been a push towards human service agencies coordinating services. Are there examples of projects that have been developed jointly between veteran transportation providers and other transportation providers? I think this is an excellent question. If anyone would like to go ahead. Frank, you are going to be an excellent person to be answering this question, I think. And the answer would be yes. There's quite a few projects. And Heather, if you'd like to talk, if you've worked with veteran transportation providers at all.
We are the veteran transportation provider in our rural area, so that might actually be better for Frank to answer that.
So I'm going to try to answer it from the perspective of the way this rolled out in Oregon. The Oregon Department of Transportation's Public Transportation Division already has 80 or 90 subrecipients. And so when Oregon Department of Veterans Affairs came along and said, hey, we have this resource and we don't know much about public transportation or transportation in general, but we have this population that is urgently in need of services. Can you help us develop the project? I think our approach might have been a little bit backward to the way the question was asked. It was like, we had this network that we could tap. We had processes in place that we could do competitive solicitations. We had oversight in place with our regional transit coordinators right there at the local level. And we could build a coalition fairly quickly of stakeholders and people who could come in and help us manage a project at scale. So it was more like, let's get our interagency agreement developed so that we can put resources in the hands of people who are really good at transit already to serve the needs that veterans present with. And then let's try to make decisions that affect veterans at the closest possible local level to where veterans will be using services. I'm not sure that quite answered the question, but that's how it worked here in Oregon. Is that useful, or did I miss the point entirely?
I think that answered the question.
I think
Yes.
so too. And just
Yes.
another, just
Go
another,
Pepperdine. Thank you.
I could say one potential innovative collaboration that it's still in the very early stages is conversations with Amtrak. And, you know, one of the big challenges, particularly in the New England area, is that the Boston VA medical centers are really the centers for specialty care, cardiology issues, surgeries, those sorts of things. And rural veterans don't want to travel into the cities. There's a reason that they live in rural areas. And when you're faced with a major healthcare issue and you got to get some kind of transportation to get there, you know, how can we make people feel comfortable? So we're trying to figure out how we can coordinate wheeled transportation and with train transportation. And my dream, and I'll just say this out loud, hopefully someone will hear, is to really get people at Phillips and the Atlas program that have been creating these mental health pods that they've been placing at different veteran service organizations to create a veterans train car, to utilize creative ideas like Brian Simpson's at Rogue Valley, where, I mean, that's kind of what triggered my thought about this veterans car, is him issuing his veteran riders earplugs, because if they don't want to hear the noise. They don't want to talk to anyone. And if you got your earplugs in, I thought, well, wow, how fantastic that would be to utilize existing public transportation in a way that would serve our veterans, not just to get to healthcare, but give them a comfortable space to get there, but also give them a comfortable and accessible way to get to the grocery store and sporting events. I just give them all kinds of things so that it's utilizing resources that are already there in a different way.
I would love to interject as well. You mentioned the behavioral and mental health needs of our veterans. We actually have partnered with one of our healthcare facilities that provides mental health services, and we have a caseworker that comes and stays in a space here in our offices where the transportation is located, and sees clients once a week. So it makes that efficient trip. They've come in to get groceries, go to the pharmacy, they can make that appointment, and they can come here instead of having to go, have to get transportation to go to a different place. And then they just hop back on the city bus or however they're going to get home. So utilizing multiple, needs during one trip to town from that rural area. So that's a wonderful partnership. It's been great. We've had people come in asking questions. They're homeless, they've got issues there, something's going on, and can I talk to somebody? And it's wonderful when she's here and I can have someone available to just make that introduction. They're just been such a great partner to us.
Thank you so much. Go Vols.
We have another question. A quick one here. Are the rural health grants available throughout the year? That may be a question for you, Kristen.
Right. I wanted to respond with, I am certainly not the best person to answer that question. That would be Mindy Lacrone, Mindy, and her last name is Lacrone. And I believe you can get her at mindy.lacrone@va.gov. She is the Highly Rural Transportation Grants Program Manager. And has her fingers on the pulse of all things HRTG in terms of the funding, the different sites that are out there, the different programs that are being funded. Who knows, there may be opportunities where programs that are already funded are looking for other transit partners locally to join their grant and their network. So Mindy really would be the best person for that.
And I can also interject that the National RTAP website has a fantastic resource guide. It's easy to navigate. You can search for things. It can kind of make connections for you as well if you're, not familiar, as well as the National Center for Mobility Management. So I came from the private sector for 30 years and never even dreamt about public transportation. And so when the pandemic happened, my whole life changed and I learned everything I needed to know from RTAP and the National Center for Mobility Management. So I would encourage you to just get on there and lose an hour or two. You'll be amazed at what you can find. And they'll even actually have you write the grant. So it's wonderful.
Okay, I am looking for any other questions. Do you have another question? Why don't veterans like being in urban areas? Have you heard, is it the noise and the stimuli?
What we've found, I believe it's a third of all veterans enrolled for VA care actually come from rural areas, and after their deployments, they choose to return to rural areas. It's like military culture is unlike any other culture. It's just something it's a lived experience, and there is very much that within rural. I come back to, and I wanted to mention this to you, Heather. Thank you for talking about the connection with your churches as one of your community resources. I worked with our rural clergy training program, and a big reason that we wanted to reach out to them is that we know that confidentiality is huge because of mental health stigma, particularly in rural areas. And the example we always use, and this is somewhat transportation related, is that if someone sees your pickup truck outside the mental health clinic, they know why you're there. If someone sees your truck outside the church, they have no idea. You could be cookies. You could be Bible study. You could be talking to your pastor about who knows what. And there's no stigma in that. And the more we talk about the Ubers and the Lyfts and know that those don't exist in rural areas and even semi-urban areas, like where I live, you can get an Uber into town, but you can't get an Uber home. So after hours is a real issue. It's going to be, for anything, medical care, work, etc. So veterans that lose their purpose, lose their way. If they can find that purpose in transportation for their church, then why not utilize a van that is sitting there as, I would like to call it, lift up instead of lift.
Okay, I don't see any other questions. And if there are any questions, please feel free. Oh, we do have one more. Hold on just a second. What's TA? Oh no, Travel Agency for Veterans. TA is Technical Assistance. NADTC, NCMM, and National RTAP. We are the Technical Assistance Centers under the Federal Transit Administration. And for the panelists that utilize Uber with their own driver / vehicle, how do you ask Uber about that?
Oh, they would be happy. It's to make that connection. They have a whole team that actually goes and does partnerships with transit agencies. And then you have a choice. You can either just partner to use their app and promote their app, or you can have your drivers in your vehicles. So we went with our drivers in our vehicles, and we've rolled it out into another city as well. The second, we have 14 cities, 3 of which are tier 1. So there are 40,000, 50,000 people. So we have 2 going now in Cookeville and in Crossville, which has the highest population of retired citizens in Crossville, Tennessee. So it's working out great.
Okay, I don't see any other questions. If you do have any questions, please send them our way. We will make sure that we get those to speakers and provide answers for you in a supplemental document. We want to thank all of our speakers today, and please look for information on registering for the webinar 2 in the series. Everyone have a great day.
Thank you.